afternoon, everybody. So Tim and I are going to share some of our clinical experiences with some kind of specialized forms of lower extremity orthotic management for this pediatric population with CP. We got a pretty good overview this morning of the mechanics of the etiology of CP, and we're just going to kind of concentrate on some of the orthotic tools that we have for dealing with this population. So it's safe to say cerebral palsy is a complex condition. Each patient has a unique presentation, unique in terms of their individual deficits and in the severity of those deficits. And in order to manage them successfully, it's really important to gather a lot of information, to do a thorough evaluation, take into consideration the family support network, and really to establish some goals for treatment and to prioritize those goals. We'd like an orthosis to do a number of things. Sometimes we're asking it to do several things simultaneously. We want to kind of consider going in whether we're primarily focusing on gait improvements, preservation of the bony anatomy, if making a difference with range of motion is always a concern. Hopefully we can address several of these things at the same time, but sometimes it helps to prioritize. Another thing we really want to consider is what other interventions are going to be happening with these patients. Are they going to be having serial casting, Botox? That's when it might be important to collaborate with PT and OT, the physicians, kind of try to get an idea of the entire treatment plan. And that's going to affect our orthotic decision making, what other interventions they're having. So I'm focusing mainly on the ambulatory population, the GMFCS 3s, 2s, and 3s. I think there's 1, 4 later on. There's still a variety of presentations within this population. The kind of feet you see in the upper left there, these kind of feet, I think Dr. Swarup was referring to them a lot earlier. This is where you see the compromised lever arm of the foot, and these kind of feet, I like to think of them as unsustainable because the kind of forces that are operating on these feet just lead to progressive deformity. The pronation, the heel valgus, the forefoot abduction, and these things are usually going along with internal rotation up the chain. The way the forces of the ground reaction forces are operating on the feet, they're just going to continue to encourage them into this kind of a pattern. And the patient there on the lower right, he's kind of got the same kind of feet. These aren't his feet up at the top, but they're very similar. But along with patterns where there's increased hip flexion and knee flexion. This patient in particular, I think we saw him originally, he was out of any kind of orthotic management for 3 or 4 years. And the reason he came back in looking for some kind of help, his family wanted to consider orthotics again, was mainly because he was just having so much pain with ambulation. So the foot at this point has kind of lost its ability to absorb shock, lost the ability to provide that lever arm. And if this becomes painful, that can be the biggest limitation to gait, the biggest limitation to function, where patients can get to the point where they're not really ambulating much anymore. So it's kind of been a theme this morning with trying to encourage early intervention, trying to get treatment early, and that goes along with orthotics as well, because this type of thing is much more difficult to try to reverse, try to retreat later. At this point, about all we can do is kind of provide some shock absorption, try to reduce pain and accommodate. But it's much more successful management to get involved earlier, and I want to talk a little bit about that, kind of some of the options for early management. Just to give you an idea, ossification at the calcaneus is starting for girls between the age of 4 and 6, for boys from 5 to 9, so that's a lot of years where we have the ability to guide the formation of the bony structures of the foot, where we can have an effect with early management. And the lowest level of that early management is the UCB orthosis. I'm sure you're all familiar with these. For flexible, correctable deformities and for the earliest management, this type of thing can really have an effect if they're made properly. And this is, I have to give credit to Don McGovern for these slides because I didn't get his name on there. So a lot of the fabrication slides I have later are Don's. I looked at them and couldn't really improve on them, so I stole them. So the lateral wall there is very important to prevent abduction of the forefoot. And those modifications where we're removing material sort of along the inside of the foot and along the lateral side, loading up the soft tissues, really these are the only effective way to get full medial lateral control of the hindfoot and the midfoot. And these, we have to give credit to Marty Carlson for doing these kind of modifications back in the 70s. And really nothing has replaced them as far as a standard of treatment for getting this kind of control of the midfoot and the hindfoot. And this isn't just limited to UCBs. These kind of modifications should be used in any kind of AFOs, any lower extremity design where you want that kind of mediolateral control. So one of the key elements of that is that calcaneal channel, and the channel that goes from the posterior, it blends right into the arch below the sustentaculum tali. In severe cases, intrinsic hindfoot wedge, a medial wedge on the hindfoot can add to that control. And then a medial outflare, what that basically is doing is just magnifying, multiplying that force that you have to control the heel. And just to show how effective these can be, this person with valgus of 18 degrees sometimes takes a little trial and error. The first shot here, we've still got a little bit, 10 degrees on the right, 5 degrees on the left. They look a little loose around the heel, tightening that up. And Don was really smart to use Vivac here where we can see through. You can see those lines on the heel. Even there's a little bit of overcorrection on the left side. And then this pretty much just neutral. So in this case, I mean, you can see how effective that is just with the UCB. You can also imagine this patient has full knee extension and plantigrade foot with the foot held in this neutral subtalar position. So we can assume that they have sufficient gastroc length to get into that position. So when you don't see that, if putting the foot in this position causes tension at the foot, doesn't allow the heel contact, or causes knee flexion, you can assume we have insufficient gastroc length, and that's when we have to consider managing with an AFO. And if we're going to do an AFO, we have to consider what position we're going to put the ankle in the AFO. So a big determinant of that is the gastroc length. You have to keep in mind that the gastroc is crossing two joints mechanically, crossing the knee and the ankle, but it's also affecting the subtalar joint. So if either of those joints, if we're seeing full knee extension, full ankle, plantigrade foot, but the gastroc isn't of sufficient length, it's going to affect that subtalar into pronation, into where we see the development of planovalgus foot. So this slide, I was interested this morning when Dr. Cerebral was talking, when she was talking about the stage 2 and stage 3 for making surgical decisions based on the length of the gastroc and on the foot, the way the foot presents. This picture on the left would definitely relate to that stage 2, and on the right, the stage 3, where you're seeing rigid deformity of the foot. And it's not completely clear-cut that one leads directly to the other. I'm not assuming that this girl would end up being a quadriplegic later on, because she's hemiplegic in this picture. So I'm not suggesting that. I'm just saying that the mechanics are the same. So you can see in her case on the left where the knee is flexed a little bit, the heel isn't touching the ground, and that's where you start to get those stresses at the midfoot, where the midfoot is kind of forced into dorsiflexion. So this kind of illustrates that a little better. What you start to see, here we go. Yeah, when the midfoot collapses, the talus begins to move medially. That blue image on the left at the bottom, you can see the force downward, creating a dorsiflexion moment at the midfoot. Then the internal rotation of the tibia on the talus leads to just increased deformity. And I'm not suggesting that this is a ground-up issue. A lot of times femoral anteversion kind of feeds into it from the more proximal joints. And you're starting to see the internal rotation, tight hip abductors, hip adductors feeding into this. But it's just compounds the problem at the foot. It compounds the deformity, just the whole kind of feedback. So this patient definitely exhibits some limited gastroc length. I just want to use him as an example because he's, where's my cursor? There we go. Just as far as orthotic decision making goes, it's fairly straightforward. You can see he's not getting any heel contact. You can see that stress across the midfoot where there's a dorsiflexion moment at the midfoot. A little bit of a hyperextension moment at the knee. And all of the force, all the ground reaction force is just on the forefoot there. We've been using a video vector lab at RIC for the last couple of years, and this is that force plate that's on the vector lab that just kind of lets us visualize what the ground reaction force is doing. It's great for making decisions, but it's also really good just to confirm what you think you're seeing with your eye. So what we're seeing there, just hyperextension moment at the knee. But this patient also has a leg length discrepancy. So decision-making wise, that makes it fairly easy orthotically because we want to compensate for the leg length discrepancy. We want to put his ankle in a little plantar flexion because clearly he can't achieve a plantar-grade foot with a plantar-grade ankle with a foot in a good shape. Whoop, got to back up there. So in his case, it was fairly straightforward to put the foot in some plantar flexion and wedge the heel. And that's not to suggest that it's always going to be the same amount. You may end up wedging both sides if it needs a little bit more to accommodate the ankle position. Also, you may put a through raise on the involved side, a heel and sole lift if you need a little bit more height. But with his height equalized and the ankle position accommodated, you can see he gets a good heel strike now. And really the telling thing for me there is that the ground reaction force is now moving normally from the heel to the forefoot, and he's getting a little bigger step length on both sides. So that was fairly straightforward, but if you're dealing with diplegic patients or you're going to do bilateral AFOs, you need to kind of decide on a position to put the ankle in beforehand. So you need a method for determining what ankle angle you're going to put them in to start with. So we've been lucky enough to have Elaine Owen come, and she's been giving a course, the pediatric gait course at REC Academy every year for, I think this will be the 7th year she's done it. And we have adopted a few of her methods into our clinical practice, and this is one thing that I think is really useful. It's just a method of determining what position to put the ankle in a solid AFO. So what she does is takes this variety of measurements with the ankle, with the knee flexed and the knee extended, and with the forefoot in each of those conditions, with the forefoot pronated, supinated, and neutral. So you're going to get an idea where it says there, note the escape pattern. When you're pushing the ankle to the end of its range, you're going to see it try to collapse in one direction or the other, either into pronation or supination. Most common, it's going to collapse into pronation. If it's collapsing into supination, the foot's got some really structural anomalies that are even more scary. But the other thing that we're looking at, that's just going to kind of give you an idea which way direction you'd expect to see your forces needing to be in to control the foot. But the other thing we're looking at is R1 with the knee flexed and the knee extended, and the active range the patient has. So between those things, there isn't just a really simple formula that just says this is the position to put it in. There's still some subjective measurement, how much resistance there is, how difficult it is to get them in that position. But then you're going to base your position somewhere in between what the R2 measurement and the R1 measurement is. The R1, if it's very high, that's just going to guide your decision. You're probably not going to put it right at the limit of range. You're going to back off a little bit. So this is just a really good illustration that kind of illustrates that point. That if, I think I missed something there, hold on. Yeah, the other, after we decide on the angle of the ankle in the AFO, we have to then determine what position we're going to put the tibia relative to the ground. So for that, Elaine has just measured over years a lot of different patients and come up with the idea that the tibial inclination, the angle that the tibia is to the vertical, if it's inclined between 10 and 12 degrees, that's the position that's going to give you the most mobility in the proximal joints. So if you imagine if you're in a position where the tibia is reclined or you're just straight at 90 degrees, you're going to have the torso lean forward to get the center of gravity over the foot. So with that incline, you've got more freedom to move the hips, you have the thigh vertical, and you have this range of motion that's available proximal, where any other position, you're just kind of stuck in that one position, and you don't have the ability to advance the tibia in stance phase to put the hip through the full range of motion. So this just really illustrates that with the patient. I know you wouldn't have somebody just in an AFO without shoes, but he's just at 90 degrees in that position. And you can see the way his hands are out in front of him in just the AFO to kind of bring the center of gravity out there. Can't get his trunk upright, so then just with the addition of the shoe and some heel wedging, this AFO is in the same position, but then that inclination is increased, and you can just see the difference in his overall posture. And he doesn't need to have the hands out front, he looks relaxed, he's more upright. So that's just kind of a function of getting that tibial inclination right. So the other thing that does, it allows what I was trying to describe, the pelvis coming forward over the stationary ankle. What you're doing is allowing that switching from extension from a flexion moment to a neutral to an extension moment at the hip. So just in stance phase and normal walking, you've got to have those three conditions happening over a stationary foot to be able to get the pelvis to glide forward in normal gait. So Elaine likes to classify pathological gait based on shank kinematics, and she's mainly looking at the tibia as the inclination of the tibia, and speaking in terms of whether they have insufficient inclination or excessive inclination. So insufficient inclination would be where you've got hyperextension at the knee, a jump gait, this kind of thing, and excessive inclination is the crouch gait. And you're going to treat those, you're going to make different orthotic decisions based on those. And the goal being to get a big step length, full hip extension and knee extension, where you get a big step, what she refers to as the big V, an active stretch of the hips and the knees in gait. So if you're starting with an AFO, that you've made your decision about the position of the ankle and get an idea that you want this tibial inclination, if you start out with some wedging without the patient's shoes taken into the equation, a position of 6 to 8 degrees is a good place to start, because you're going to imagine you're going to build that up with the heel of the shoe and bring it further forward. This kind of illustrates the differences in the AFO design between those two conditions where you have excessive inclination and inadequate inclination. With the hyperextenders, you're going to have a flexible toe plate most likely. You're going to have possibly a squared off heel on the shoe to encourage some knee flexion. The crouchers, you've got to get more heavy duty with the anterior shells and the rigid toe plates and that type of thing, and we'll use sometimes what you call a point loading rocker that just extends that lever arm out further. It's all about just providing that lever arm that the foot's no longer capable of providing. And the shoe's going to have a huge impact on that. The heel of the shoe, the shape of the shoe, the rigidity of the material, those all have to be taken into consideration. Again, Don slides with some fabrication. The one thing to keep in mind, if you're making these rigid toes with the MTPs, with the walls extended, you can't really change that after the fact. So you kind of have to go into it planning. If you're going to extend the MTPs, make them perpendicular to the tibia, you've got to kind of have that modified into the cast, and it's going to be set there. And then this shows at the bottom a polymer heel wedge that's kind of built into the AFO. You can also make that with crepe. Lifts can go on the shoes, on the outside of the shoe. That part is very flexible as far as how you provide that height, just so you provide that height. And this is what Elaine calls the stonker, is the a very rigid AFO with the anterior shell, corrugations at the ankle. So just a couple other examples. This is the same guy from the beginning that we decided finally, because you could still see a little knee hyperextension, we added a little more wedging to his shoes. I think it's the same AFO. But I just wanted to show this because it shows that ground reaction force, how it's affected at the hip, that we're getting closer to a hip extension moment there. In the first one, you can clearly see there's not a usable hip extension moment besides what it's doing to the foot. This is a very strong knee extension moment with the patient barefoot, that just by equalizing, getting the inclination right and getting the ankle in a position where the gastroc is of usable length, you can equalize those force moments, and it's going right through the knee, right through the hips, so get a little bit of a hip extension moment. So this is a little bit of an older patient, and would be an example of excessive tibial inclination in the first image. She had been out of AFOs for a while, and that's always a kind of a challenging situation to get something that a patient's going to accept when they've been out of AFOs, or if they are going to get back into wearing them. That can kind of mess with some long-standing habits that they've had that they may not be able to change, some compensatory patterns that will be difficult to get over. So mechanically, I mean, even without the vector lab, you can see that there's a much better vertical thigh, more extension at the hip, much more upright posture. But I have to admit, this patient I talked to recently, this was a couple of years ago, and she hadn't been wearing AFOs for several months. We're probably going to be following up with her again soon, just deciding what the next move is, because it's kind of the thing that the picture doesn't show. With that better alignment, the effort that she has to put into it to make that work, just to really get the benefit and to change those compensations to where she can utilize the AFO. It's a lot of work. It's something that the patient has to be able to commit to it and make it work, especially the older patients. Now the patients that are more, this is actually kind of post-op management. This patient had had a lot of releases. When they're using a walker, it's kind of hard to trust what you're seeing on the force plate because they're putting a lot of force through their upper extremity. And there also is the problem of the wheels getting on the force plate, so we're trying to guide them over it. But this patient's just moving really slow, taking really small steps. So it's kind of limited how much you can harness ground reaction force when they're using a walker because you just can't trust that really having the effect you want it to when they can put the majority of their body weight on the upper extremity. But we did go ahead and put his ankles in a little more opportune position, trying to maximize what length he had. And it did have an effect on getting better knee extension, a little longer step length. And that whole benefit there I would just attribute to getting the ankle in the proper position so that you're maximizing what gastroc length they have. Okay, so I want to cover this too before Tim starts, and this is something that's a completely different thing. We've been using devices that are, you probably have heard them referred to as a Taos walker or smart walker, a solo walker. Is anybody here using these kind of things that are like a RGO and a wheeled frame? Anybody familiar with those? Yeah, okay, got a few people that do. So they have been around for over 20 years, but I still don't think they're in too wide a use. They basically are a full RGO, even a thoracic HKFO, because there's a thoracic section to them, that's mounted in a wheeled frame. And the patients that would be using these would be otherwise not ambulatory patients, patients that would be using a wheelchair for mobility. And it allows them hands-free mobility, which is a little different for most of them. Some would be patients that have been using like a Rifton pacer and that kind of thing, where there's a little saddle that they can put some of the weight into. And the whole purpose of them is guidance of the limbs, so it's patients who have spasticity, and we're just using the orthosis to guide what movement they have and to partially unload them so that maybe they can be upright longer than they normally would. So some of the things we talked about earlier, like the ossification of bone under weight, that's something that's going to be allowed for patients that otherwise wouldn't be getting that. You got a lot of variability usually of how much weight you're actually putting on their lower extremity, so that you can have that effect for them. Definitely reduced risk of contractures with standing, getting upright, and there have been benefits shown for respiration and just interaction with the environment. So yeah, these are patients that otherwise would be in a wheelchair. They can be pretty involved, so you always want to kind of screen the family's involvement. It's going to be a lot of work on their part. They have to come back for frequent adjustments for growth and that kind of thing. They need to have a place big enough to use it, so there's some limiting things there that you just kind of want to find going into it. The earliest design was developed by David Hart, a medical engineer in England, in the late 80s, 89 for the first version and 94 for the second version. That first one used some kind of cabling system like an RGO, I think, and the more recent versions have just straps that guide the feet. And I think they have, both of those had some sort of a hydraulic type strut that did the unloading. And then this one's made in Ontario, the Smart Walker. It's very similar to the Mark I with just the straps instead of the cabling, also with a hydraulic strut. The Taos, instead of the hydraulic strut, uses a crank type mechanism that in real time you can just go behind the patient and kind of change how much unloading, how much weight bearing they have. And the Solo Walker was really similar to the Mark II Heart, but it's no longer in production as far as I know. If there are other ones you guys know about, let me know, because that's the only ones I know of.
Back to your former slide.
Yeah.
They would be primarily using other means of mobility. These things are still just a therapeutic tool, aren't they?
Right. This wouldn't be, yeah, exactly. This wouldn't be replacing a wheelchair. No, I'm sorry if I made that, didn't make that clear. It's definitely like an ambulation gait training device. Wouldn't be something that you're taking them shopping in or something like that, although I have seen them used that way occasionally. It's not the intention. It's meant to be a gait training device. So mostly CP kids using these. They have to show that they have some type of the ability to initiate a step to be a candidate for it. If they do have scissoring or internal rotation issues, those can be controlled. That's actually what the device is very good at, is controlling that kind of motion. Head control is key. If they can't hold their head up, they probably aren't going to be able to do too much with it. In some cases, if they tend to overextend and end up with their head behind, there are blocks and roll bars and things that can be added to them, modified that way. So I've seen some of those kids actually do pretty good with them. Vision, something kind of touchy. I've seen kids with poor vision do okay with them, but it's something you definitely got to consider. If it's complete blindness, they're probably not going to be able to get the most out of it. The restriction here on ankles to plantigrade, we know we can put wedges and things and kind of make that work, so that's not a deal breaker. Stable hips definitely is. We'd want them to, if there's any question about that, go see their physician first and make sure that we've got good hip stability before they start using this kind of device. Cognitive evaluation is important. We want to be sure that they're able to follow instructions, that they understand what they're expected to do in the device, and just the ability to enjoy it. I mean, if the kids enjoy it, that's when they're going to get the most out of it. Yeah, and just what other kind of devices they've used. Like I said, sometimes the pacers, Riftons, and those kind of things have what success they've had with those can kind of determine what they'll do in this. I'm not going to really go over individual measurements. These are the kind of things they work on in them to achieve upright posture, build tolerance for standing, practicing just weight shift between the limbs, and just walking with purpose, having a goal, trying to get to it. Steering control is a little more advanced. Some kids never quite get that, so you have to have durable walls at home. Yeah, they're very adjustable. Kids can use these same devices for years because they have a lot of overlap in the bars between joints. There's a lot of growth adjustment. So I think the Smart Walker had different size frames. That was the only issue that you had to sometimes go up a frame size. So this is just an evaluation video. So this patient is just demonstrating that with support of her mother, she's able to initiate a step. She's got adequate either adductors or hip flexors to take a step. If she's scissoring like this, which she does pretty prominently, that was not a problem once the device was on, that it was able to control the scissoring really well. And it's kind of like sometimes it'll kind of harness those adductors and use them for flexion a little more effectively once they're in the device. This guy is just a natural. At his first visit, he started taking off. After a few trial and errors, he started looking like this. So this is kind of what we hope to see. And in this case, we don't use the guide straps at all because he's able to keep his feet right underneath his torso, just in a really nice pattern. He's taking small steps. Hopefully he can take a little bigger steps at some point, and the straps might help with that. They may actually work on that. A couple other videos of these guys. This one's a little more commonly what we see on the first visit, having a little trouble. Now, if he consistently kept getting his feet ahead of him, we'd probably put the posterior guide straps on. That's the idea with them. He can do a reciprocal step, but if he's getting both feet either ahead or behind. I have another example of, what's that?
Is he sitting on a pommel?
No, there's a little seat that you can use for donning, and it comes off, and you put it in the back there to get it out of the way. I haven't seen too many people actually using it for donning. For larger patients, it might be useful that you can sit them there and then just crank them up off of the seat. But this was the first time I had seen this. This guy just kind of got in the habit of taking quick little steps and then coasting with his feet dragging behind him. And he just liked doing it. I mean, he could do it fine with his feet in the middle, but this was just fun. So we couldn't have him having that much fun, so he had to put the guide straps on. Didn't like it at all at first, but it did manage to get him back in the pattern of just taking little steps. So I'm sure his mom lets him run with it once in a while and treat it like a skateboard. So I have some other little. We good? So I just wanted the benefits. I kind of went over this anyway. I want to give Tim a chance to talk about FES because that's really interesting. Yeah, just the fact that they probably have been using their hands anytime they're up, and this is kind of a whole new thing for them to be hands-free. Guidance of the lower limbs, their independence, lets them explore the environment. We've seen improvements with all kinds of standards and that kind of thing with bowel and bladder function once patients get up, and the increase of bone density with weight bearing. And just their self-esteem and social interaction, it lets them interact with their environments in a little more direct way than they're used to doing. Okay, and Tim is going to tell us some things about using FES for pediatric CT.
So I wanted to spend some time today and kind of share our experiences with functional electrical stimulation, particularly with the pediatric populations. I was fortunate enough to be able to kind of be in on the beginning when we started our multidisciplinary FES clinic for adults at RAC, that we do a monthly clinic and to integrate the device into therapy. So over the last probably year and a half, 2 years, we started to bridge that gap into pediatrics as well. So it's very different beast when we start using this on pediatrics, but we've had some good experience, so I want to share some of those for you. All right, so just a brief overview. Functional electrical stimulation, what is FES? What are we talking about when we start talking about it? So it's a method of applying low-level electrical current directly to motor nerves to restore function. The key here, functional electrical stimulation. FES is a category in its own. It is different than traditional NMES or muscle stimulation that a lot of people may have had in therapy for pain or different strengthenings and things like that. The difference here is that we're trying to, our main goal is to get the functional movement. In this particular case, it'll be over the dorsiflexors and everters at the ankle. The other part is that we are stimulating that motor nerve. We're not trying to just reach an action potential in a muscle to get a contraction. We're actually trying to go for that peripheral nerve. So we're trying to stimulate that nerve. I'll go into exactly the nerves, but so distally by stimulating that nerve, we are introducing a sensory signal into the nerve to get distally to get a functional movement, and then proximally by using the central nervous system, we're hoping that we're actually affecting the central walking patterns and kind of looking at the actual pattern of gait and how we're interacting in with the patient's actual ambulation. In FES that we're going to talk about for the lower extremity, for peds, really we're trying to dorsiflex the ankle during swing phase so that we can achieve toe clearance and also a heel-toe pattern and gait. Obviously, if we can get that increased toe clearance and better heel contact, we're going to get improved mobility, hopefully decrease energy expenditure and effort on the patient's part. And kind of the most exciting part about FES that we're finding is we have the potential to possibly do some, re-education of the muscles and using that neuroplasticity, which is something that is, as Bridget was commenting on, the plasticity, that's something that we don't see quite as much in a lot of the adult patients that historically have been treated with functional electrical stimulation. So we hope that, moving forward, we'll be able to get through some research to show that we're actually maybe getting some retraining. So for FES as a whole, indications, the main indication is that we ideally are going to be using this on patients with upper motor neuron lesions. So obviously in the adult CVA and stroke, cerebral palsy is absolutely one of the most appropriate populations for this. Traumatic brain injury, MS, spinal cord injury, and then that FSP as well. Not very common, but it is one that is there. Contraindications. It's a little bit looser, when you first get trained with FES, any type of motor neuron lesion that's lower, that's not in the central nervous system, any type of peripheral nerve injury, a lot of the times, if there's any nerve damage, the textbook answer is it probably won't work. There are some, once you get more and more experience with FES and you look at patient presentation, you do have some potential maybe if there's a partial nerve injury or something like that. So it's not an absolute contraindication. An absolute contraindication is any implanted demand type cardiac pacemaker defibrillator. That's an absolute contraindication by the FDA. Malignant tumor in the area of placement, any active DVT in the area of electrode placement. There have been some patients who have that, mostly in adults, as you'd imagine, but usually, cardiology will usually clear them. Obviously, pregnancy is hopefully not going to apply here to our pediatric CP. And history of seizure disorder, that's the big one. That's the most common one, especially with our kids with CP. A lot of them have some sort of seizure disorder, whether it's ongoing or right after birth or right after their, initial insult. That's something that you really just want to check with the medical team, with the neurologist. I've had to call a lot of physicians, a lot of neurologists to get a seizure clearance. I've never had any of them ever say no. Most of the time they're irritated that I called because they say it's so peripheral, there's no way it could cause a seizure. So usually it's not a problem getting the clearance, but it is an FDA instructed contraindication that is part of your screening. So it's a good idea as well, because a lot of times with pediatric patients, a lot of your referrals come maybe from a therapy center or from somebody who saw it on TV or read about it on a CP Mom Facebook website or something like that. A lot of times they'll call. That's a really good thing to screen for over the phone, because a lot of times parents call for information before they schedule an eval with you. Get the seizure question out of the way usually over the phone, and then they can hopefully come in with a clearance so they don't waste a trip, and then you can't even do your initial eval. Because really, to do your evaluation, you're introducing electrical stimulation to the limb. So if they come in and you don't have a seizure clearance, that's a wasted trip. You can't even screen them. So just kind of from experience. And then considerations, like I said, lower motor neuron involvement. Different patients. I have had patients that have come in with prescriptions that even have diagnoses like spina bifida or some sort of peripheral nerve disorder, but they can show some active dorsiflexion, which would indicate to me that that pathway is somewhat intact. In those cases, I have evaluated, and a handful of patients have actually done very, very well with it. So it's not an absolute, but it's definitely, until you have a lot of experience working with it, I wouldn't go into any of these kind of fuzzy areas with FES. So the available systems out in the market, there's the three main systems really that we're going to come across, I think, as orthotists is the Walk-Aid by Innovative Neurotronics, the BioNest system by Ness, and the Oddstock medical system. That's the Oddstock dropped foot stimulator. That's the ODFS PACE. So the Walk-Aid system is distributed by Innovative Neurotronics here in the United States. The Walk-Aid system is a one-piece system. The electrodes are all housed inside of the cuff, and it's a tilt sensor and an accelerometer. So there isn't a heel switch with this. It's programmed, by computer via Bluetooth to the patient's gait. The BioNest systems, they have the L300, which is just below the knee for foot drop. They also have an L300 Plus system as well that's above the knee that can be used either for quadriceps or hamstrings, depending on the patient's need. As far as pediatrics, I don't think that L300 Plus is sized down for pediatrics yet. So it would just be the below the knee component for the BioNest. And then the Oddstock. The Oddstock is also a heel sensor. It is not a wireless system currently, so there is wiring that needs to run from the device to the actual heel switch and the electrodes as well. So a little bit more componentry involved in that one. So, they're all systems, these are all FES systems. They all deliver pretty much the same type of stimulation to the actual nerve itself to hopefully get the same response. It's really the mechanism of action that you're going to see the differences in. And obviously, heel switch versus tilt sensor accelerometer is the biggest difference really between all of them. And really with that heel switch, it is a very simple on-off connection. If the heel's on, if there's pressure on the heel switch, the device won't fire. If there's pressure off, it's pretty much going to fire. So, if you with the heel switch, if you have a patient who tends to never even make heel contact, even if you're dorsiflexing throughout swing, that device really isn't going to be able to time with the patient because it's not going to be able to cycle through. And then the basics, like I said, all three of these systems pretty much follow the same idea of what we're trying to do. So they're all programmable, they're battery operated, and they use two specifically placed electrodes. So they're going to have an active electrode and an indifferent electrode. Usually it's black and red. So the active is going to be putting that stimulation in, and the indifference really just pretty much completing the circuit to pull it out. So it's going to make a loop kind of through. So ideally, if we have two electrodes and they're making a loop, we want to do that loop to pass over the correct point on the nerve to get the desired motion. So that's really what we're doing when we're, moving them around and kind of fishing for where we're going to put them. Like I said, dorsiflexion, we want toe clearance. So ankle dorsiflexion is our main goal pretty much with FES. However, if you remember back to anatomy, your perineal nerve, the common perineal nerve has a superficial and a deep branch. The deep branch tends to go deep right just distal to the fibular head pretty much. So, and then the superficial stays kind of more along the lateral side of the leg. That superficial is going to control more your ankle kind of everters, pull that foot out into eversion. Your deep is really going to be that true anterior tibialis dorsiflexion. But really, we're usually going for a good mix between dorsiflexion and a little bit of eversion. If you think a lot of our kids' spasticity tones is a lot of them tend to go into, plantar flexion and supination with a lot of their tone. So if we hit straight anterior tibialis, usually you get a lot of inversion and a little bit of dorsiflexion because you're almost just feeding right into what their tone is. So we're usually kind of trying to draw that foot out into eversion. So most of the time when you do your first evaluation on a patient, if you're getting dorsiflexion and eversion, you pretty much go with it. Unless eversion, it's just like, kind of Ken was talking about in his evaluation of the foot. The foot's going to want to escape somewhere. So I don't want to push it towards that point where it's going to escape out at me. So, if they're coming in and have a completely rigid rocker bottom foot, hopefully I wouldn't be doing a walk aid evaluation on them in the first place. But if they really are going into that strong eversion with tone or deformity, I may not want to get that part. I may just go straight for the anterior tibialis. So it all depends on our clinical presentation that we're looking at, what our goals would be for this stimulation. So, like I said, over the past 1 to 2 years, I'm sure there's been practices and clinicians that have been using it for longer than that. A lot of the systems really were, personal devices out on the market, maybe 2005 at the earliest, and really were marketed towards hemiplegic adults. So it was really stroke MS, really when it kind of first started to pick up some speed. So I would say over probably the past 1 or 2 years, that's about how long we've been doing it at RIC. And we started pretty slow, and now it's really ramped up, where I probably evaluated 100, 150 pediatric patients now for it, with some good success. So it's starting to take off. It's definitely becoming very, very popular in kind of our CP network. So parents are very, very familiar with this and learning about it. One of the downsides with a lot of this new technology, particularly the walk aid, is pretty much everything you see online, even parents posting it, it's the perfect candidate with minimally involved hemiplegic patient with a little bit of drop foot. This is their AFO that they hate. This is walk aid. Kid loves it. They can run. That's it. So that's most of the time when people come into your practice and want walk aid, that's what they think this thing can do. So, managing expectations, I'll talk a lot about that later, is a big part, especially with pediatrics. Obviously, there's limitations. Number one that I see, it's size. All of them use the same electronic device. They just have scaled the cuff down. So it's really not, it's not designed for a pediatric leg. And depending on the patient, size of the patient, their base of support, like all of that, that device is pretty prominent on the leg. A lot of times, so much that I would argue really it's probably more bulky than an AFO, on a kid. So reducing the bulk of an AFO isn't always really the argument for peds. Sensitivity to electrodes. Just the electrodes themselves. I'll talk about the stimulation itself a little bit later, but just the electrodes themselves. Very sensitive skin. You're putting, kind of a moist, kind of water permeable electrode onto the limb for 8 hours a day. Skin sensitivity is going to occur. I have found it more often with kids than adults, just that sensitivity. The other thing is too, with kids versus adults, there's more dirt under there. There's sand, there's more water, there's a lot of different things that are, especially like sand. Sand seems to be the worst because you got sand in between the electrode and the skin. It's moisture, and then you're also shooting electricity through it. So that skin really can get raw. And a lot of times if they come in with a rash, that it lasts. It's a couple weeks, they're out of it. So you really have to kind of manage that. Tolerance to the stimulation, like I noticed. Like I noted, I'll talk a little bit more about that in the actual device setup. And then gait, speed, and cadence. Kids are not little adults. They sure don't walk like little adults. So, a lot of the basics that everybody goes and gets trained in FES, they don't really train for pediatrics. Pediatrics is going to come along more with your experience. I think most of the training courses that I've been to and also led, usually people say do adults first. Once you get it, then start it on the kids that you've known for a long time. I think that's a pretty good way to view it. So I kind of went over our common pediatric population. Cerebral palsy is definitely the biggest one. I just put in there just to pique people's interest. It works really, really well with kids with idiopathic toe walking. That's not our subject, but it's kind of that kinesthetic reminder and also that muscle activation reminder to get them to try to get the heel down. Maybe worth a try in your practice as well. Okay, so big considerations that I have for pediatric FES, regardless of the device. It's number one is age. One of our reps that I work really closely with has used it successfully on a 3-year-old. The youngest patient I put it on is 4, and that was a very mature 4 that I have known since she was, not even 1. So, known the family, so that's, that was, a little bit more of a risk to try it, but more important than age, obviously, maturity level. A mature 4 is a lot different than, a less developed 4. And family support as well. If the family is very, very into this and really wants this to be a viable option, and they're going to put in the time to get the kid broken into it, much more reasonable. And then their current treatment modalities, the big thing, are they in an AFO? Are they compliant with it? If they're not compliant with the AFO, they may be better with FES because because the shoe thing is out of it. But a lot of the time, it's still a device they have to put on their leg, and they have to use it. So, that's a big consideration for both peds and adults, but especially with pediatrics. Limb size, obviously, just because of the device itself. You got to be able to get that on and suspend it on the leg as well. But I think maturity level and family support and motivation are the biggest two. I put current modalities on there as well because you have a lot of physical therapists, occupational therapists that are using e-stim on kids as well. If they've had previous exposure to e-stim with their physical therapist that they've known for years and see 3-4 times a week, that's a plus because I'm doing the same thing they do with their physical therapist. So, for the parents to be able to say it's just like you do at therapy, it's much easier. And if I know the therapist or, can get in contact with them before I even evaluate, I usually ask the therapist if they can to try to introduce e-stim a little bit on a low level. Just because, a lot of those pediatric therapists, they see those kids a whole lot more than we do. So, they're a lot less scary. So if they can initiate it before they come in and see me and I scare them, it's much better off. So our RIC model, Dave and Ken both were talking about GMFCS level. We're talking on, the other end of the spectrum now, 1, 2s, and 3s, pretty much 1s and 2s. So those are those kids that are, pretty much fully ambulatory, maybe with a little bit of support, a little bit of holding if they're really playing, but the more mobile kids. I would definitely say ability to ambulate short distances with no orthosis is definitely, I think, a pretty reasonable requirement for these kids. And most of the kids that come in that are actually going to be a good walk-aid candidate probably don't wear their AFO full-time anyway. They're probably the kids that take it off when they get home. Because they can get around, they just need a little bit of help with that toe clearance. R2, dorsiflexion range of motion to neutral. I will not do it if they cannot at least get to neutral passively. I think that's the biggest potential where this device is overused in pediatrics because, we see a lot of kids come through clinic and come through therapies. Those are the kids you could tell the walk-aid is working great. It's timed perfectly, it's firing that anterior tib, but you can only bring it so far. So, if you're only bringing it to -2 or -5, generally what they're doing is they're still, midfoot or plantar contact. They're really not getting a heel-toe contact, and they're probably then also not in an orthosis that's managing the midfoot. So generally, you're just entering them into stance at plantar and then allowing all that dorsiflexion to occur at the midfoot again. So you're really just adding to the problem. So definitely neutral range of motion. No excessive knee flexion during the gait, same thing. We're firing the ankle dorsiflexors, which is gonna pick up the toes. When the foot's on the ground, if it fires, it's just gonna do this. So, those kids that just walk with that, even that slight crouch or that jump knee, we're probably just going to contribute to the problem. So I wouldn't do it on them. And then Ashworth scale 2 or less, so that 2, just, as a reminder, that's that marked increase in tone, but it can be easily moved. So we don't want to elicit more spasticity in these kids. It's obviously speed dependent. We're introducing a pretty strong electrical current that's going to quickly dorsiflex that foot. Even though it's coming internally, with these kids, they don't necessarily have that, normalized, antagonist muscle relationship where just because we're dorsiflexing, they can't plantar flex. I mean, you can really elicit tone. The other part about it, if they have that really, really strong extensor tone, I'm also introducing stimulation that isn't the most comfortable thing in the world, so spasticity is probably going to go up. And then apprehension as well, because I'm a new person putting a device with wires and putting electricity in their legs. So, spasticity, it can be a real limiter. So I would just really kind of watch that and see. And a lot of it, you're not going to be able to tell till you get the device on them and have them walk. Sometimes they're spastic initially and they take 5 steps and they're fine. So, it's just kind of part of your overall evaluation. So I think the keys to success that we have found, both in our adult clinic situation and then bringing that down to pediatrics, I think even more so in pediatrics, the team approach. So we want buy-in from obviously patient, parent, but physician, physical therapist, the whole team, because it is a different device. We have totally different goals, therapy goals, so if it's not going to be incorporated into their multidisciplinary plan, it's really going to not do too much good, which is pretty much the same with a lot of our orthotic management. And the joint evaluation process, I think, at least with a physical therapist, I think having that at least 2-person team with orthotist and PT from the get-go is excellent. It helps with a lot of things down the road as far as reimbursement, which I'll talk about, but I think just having that joint evaluation to clearly identify the actual biomechanic therapy goals that we use along with it is very helpful, particularly for the families. So they have an idea this isn't just a magic thing you put on. And then, like I said, with whom is the patient most comfortable? If they're coming into one of our pediatric clinics and they see a pediatric physical therapist 3 times a week and they want them to try the walk aid, I'd much rather go and evaluate during a PT session than I would have them come for an orthotic evaluation. Just so that it's integrated, it's comfortable, like I said. The least variables we keep changing up on them with something like this, I think is better. Like I said, previous exposure to e-stim is a plus. And like I said, if a lot of the therapists are really very open to doing e-stim a little bit with the kids before you see them, it just really helps us to kind of break it in. And then I think as far as managing family expectations, first thing I say is, I'm sure you looked at this online on your way here, that's the perfect case scenario. Very few patients really can walk like that right away, so that's not going to happen. And then number 2, that continuing the use of any orthoses or specifically nighttime AFOs or any nighttime stretching things is not a failure of the FES. So a lot of people think that if it's a total failure if they still have to wear their AFO part-time or if they're still wearing a night AFO. If we're going to get this $5,000 device, why am I still also getting insurance billed for an AFO? Because it's a complement. So we're using it, a lot of times I just say we're using it actively during the day and stretching it at night, and just I kind of set that from the get-go that we're going to do that. And then also, like I said about the anatomy of the foot, most of the kids that we're in, it's not just an isolated drop foot. It's not CP is not going to be your flaccid drop foot. They're going to have some tone, probably left arm dysfunction. So I try to manage the bony anatomy of the foot as well. Usually UCBs, but aggressively modified UCBs, kind of like Ken was showing, to really try to hold that foot. Some kids will do SMOs as well, but I usually, when I'm talking to the physician, I try to get that on the initial prescription, walk aid and UCB or SMO, so that we can just move forward with that. So we don't have to wait until they go see ortho with the walk aid and then I get a call because then their foot's breaking down. I try to just do it all at once. So our clinic model, just to kind of review, everybody's going to be able to, hopefully, you can do this in your own way. We're very fortunate because we're all in the same building at RAC. So, it's very easy for me to do a clinic model because it's an email and get on an elevator. It's not that easy, I know, in practice. But we do it once a month. So, it might be a little bit more feasible if you can just get together. And this is just for the initial evaluations. So it's a physical therapist and an orthotist are present for the initial evaluation. A lot of the times, like I said, the patient has some sort of established encounter in PT, so it may just be another session for them. But if they're not currently in PT, we use that as the PT evaluation as well. And they can directly state it, you know, when they start doing their insurance certification and everything, this is a goal we're going to work with FES, and they make that part of their therapy goals, so that works well as well. The really great thing about having that multidisciplinary team is for the baseline testing. So while I'm getting things set up for the FES and talking to the parents about this is what we're going to do, this is what FES is, go through the contraindications, the therapist is out in the hallway doing baseline outcomes measures. So generally, you know, usually for the kids, they're going to do probably the 2-minute walk test, timed up and go. Really, it's the 2-minute walk test and the 10-meter walk test. With kids, you usually don't see too much of a difference because kids are walking pretty quick. If they're ambulatory with their AFO, they're going to be maybe a little slower with the walk aid at first. But unfortunately, those two tests, those time tests, that's what insurances ask when you appeal. They want times. You know, not as much subjective. So we do all the baseline testings, and then that way it's in the chart as part of our evaluation. It makes it much easier down the line if we have to appeal. And then after clinic, so if the patient's a good candidate for the device, they show you know, good response when we can do the programming. We get them in at least 1 to 2 times a week as their therapy schedule for a couple sessions, just to see how the child does from day to day. Not so much with kids with CP, but a lot of patients globally are using FAS on. If they have all morning PT appointments during their trial, they may call you once they get a home trial or they get the device that it never works in the afternoon. It's because their fatigue may be up and they may be walking differently. So, you know, we try to give it some time so that they're actually using it and we can test. And then the part of the PT goal, part of their educational goal, documented goal, is actually working with the family as well for independent use. So that's identified as one of the patient goals in therapy, so that when it does come time when they're ready to do a home trial, or if the device gets approved by insurance, we know we can be confident that they can take the device with them. Because me sitting in an office talking to them for an hour with an instruction manual is not going to teach them how to do it. So a few times a week over a month or so really helps. And I mentioned the home assessment program. We do at RIC, we have a number of units, and we let kids take it for usually 2 to 4 weeks, usually closer to 2. We do that usually because insurance is still pending in that time as well, or we've gotten, a denial or have to appeal a lot of the times, unfortunately. This gives the family a little bit of time to keep using it on a more consistent basis while we're waiting for insurance information, but also if this may be something that they're willing to purchase out of pocket, gives them the opportunity to take it home and try it every day versus just paying for this thing and hoping it works. So we pretty much everybody, even when they have an insurance approval, if it's not barring extenuated circumstances, I usually still make them do the home assessment because it doesn't hurt them at all. So. And then, that's all steps towards determining, how viable is it for a definitive device for the patient. And then exercises for home and PT. Our therapists are getting more and more comfortable with this. There's a few that have kind of really taken an interest in it, so they work with it a lot. Number one, they do a lot of treadmill training because it's consistent steps, and they try to just get that consistent kind of training. The other thing is the selective motor control aspect of it. A lot of these devices have an exercise mode or something that they're going to instruct the families to use for home exercise. The biggest thing is that the kids can feel when the stimulation's happening. We want them to try to volitionally dorsiflex the foot. That's a lot of what they work on. So a lot of times they'll work on that Dynadisc or that rocker board to get them to really exaggerate that dorsiflexion when they feel it. And then one other thing that we do have at RIC that's actually starting to pop up at more pediatric physical therapy locations, I think, and it'll start being more nationally as well. It's called the Intelligence Stretcher. It's a device that kids can sit down on. They actually play video games, and they control it by dorsiflexing, flexing the knee, extending the knee, plantar flexing. So as you can imagine, it's a great complement to FES in patients. So a lot of, probably 80% of our patients that come in for intelligent stretcher, we usually get an email from the therapist to at least try the walk aid. So, it's kind of a neat device. You know,
In conjunction with the FES?
yeah, usually, so they wouldn't be wearing the FES while they're doing this, but they may do their overground training part of the physical therapy visit with the FES on, and then do this portion. So I think they usually do like hour-and-a-half appointments. So they might do an hour on the intelligence stretcher and then half hour on the treadmill or half hour over ground. So they put it on. And it just basically what it's doing is trying to maximize their active range of motion, and then it helps them the rest of the way to the desired passive, with the thought that with repetitive use of those muscles and kind of cognitive cortical control of those muscles, that they'll start to increase that active range of motion window. So it goes hand in hand. So if you do have a facility that's getting one of these and they kind of approach you about it, really, really good use with the FES. That's another picture there. And then I just want to do a little bit, I know we don't have too much time left, but just on the programming, I did do, you can do for pediatrics, WalkAid, Bioness, both work. I have used them both. I do use the WalkAid more. I think especially for kids, I don't want to put something in their shoe that's going to hang out of the shoe. I think that's potential for disaster as soon as they take it to school. So I do use pretty much WalkAid the most for pediatrics. I think the tilt control has much more option to try to match the patient's gait. Like I said, kids aren't just doing a heel-toe gait at one speed all the time. So having more of a tilt range, even if they don't maybe hit their heel, if they're running or something, we can get it to work. So just a little bit kind of an overview. This is screenshots of the Walk Analyst software for WalkAid, but it applies globally to all the FES. First thing you're going to do before you even touch the patient, turn your pulse width or your intensity all the way down. Pulse width is basically how big is the charge. So, the charge is going to go at this level, but is it chunks like this or chunks like this? So it's more, we're trying to get more motor units activated if we turn this down. So we're going to start by minimizing it. We may bring it up, but we'll probably minimize it. And then this is the kids are not little adults thing. This is, the same time window, and I just drew it out. So we got adult on the top and peds on the bottom. The peaks are going to be swing phase, and the valleys are stance. So obviously, adults have a clear swing and stance. Kids, this ped has it as well, but it's very, very condensed, and that stance phase is extremely short. So if you think about any device that's trying to go through a cycle, whenever you introduce a really, really short window where it has to turn off cycle and then turn back on, that's really, really tough. So if you're looking at, a heel sensor where they may not even be hitting heel first all the time with running, that's a really short window to be able to fire on time again for them to initiate the next swing. So like I said, peaks and valleys. So the kids' graphs are going to look much different than the adult graphs. So basically, with all of these devices, you're going to have a minimum time, a maximum time, and a wait time. A wait time makes sense. That's stance phase. Once it cycles through once, it's got to stop and wait a certain amount of time before it turns on again. So that translates. That's when the foot's on the ground. It's waiting to go again. And then your minimum time and maximum times. So WalkAid and Bioness, you have to set a minimum time, which is basically once the thing starts firing, it has to go this long before it turns out. It's an absolute, no matter what. So, if it's Bioness and I take my heel off and heel down, even if the heel's back on, if that time hasn't elapsed, it won't turn off. So that means it's going to stay on in the stance phase and then probably put them into more of a flexion. And then your maximum time is the same thing. It can't go longer than this. So even if I'm taking a really slow step and my foot's in the air, once I hit that max time, it's going to stop. So obviously with kids, you're going to keep those all to a minimum because they're going to vary a lot. Their speeds are going to vary a lot. And then this would be your pediatric. So I'd have a really, really low minimum time because if they start running, I can't keep up in their walking program. Maximum time is really, really low because there's quick steps, and then the wait time is usually like 0.1 seconds or 0 because their feet are really not on the ground very much. And then just to review, there's really not a whole lot of FES research out there, and there's even less pediatric FES research. A lot of the FES research out there is based more on acceptability of the device than the actual biomechanical changes that we see. There absolutely is not something over time. So, I always tell patients you get 3 potential benefits of using FES. Number one is the orthotic effect, where you have it on, you're going to walk better if it's appropriate. Number two, the therapeutic effect, because you're actively engaging a muscle, so it follows that you're hopefully going to be strengthening it. And then the third potential should be carryover, especially for kids. We should be getting some retraining. I've definitely seen it, anecdotally, where kids, even after the first couple times they use it, they do walk better for a couple minutes after we take it off. There is not research out there showing it. So I think that's going to be, really the forefront of what we need to research, particularly for reimbursement. So this is just, this was done at the NIH in Bethesda. This, I think, is probably the best PEDS research for FES out there. This is the one that I send to insurances when I peel. So it's acceptability and potential effectiveness of a foot drop stimulator. So they got 21 subjects between 7 and 19 years old. They all had to have spastic C-plead. They did not specify hemiplegia, diplegia, or anything. GMFCS 1 and 2. Oh, they did. Hemiplegic, sorry. Unilateral foot drop. So they had 21 subjects, and then exclusion, no Botox in the past 4 months, no lower extremity surgery in the last 12 months, and they had to be neutral ankle. R2 had to be 0. They could not have any plantar flexion contracture at R2. So number one was acceptance, and then they wanted to look at some of the kinematics, and then also some other more kinematic and kinetic measures. So they found 19 of 21 accepted the walk aid. One could not tolerate it above the motor threshold, so they couldn't even get enough stim into the leg without the patient refusing it to even get an active contraction. And then dystonic posturing triggered in another. So just, some complications with getting the correct stim. They did 6 hours of daily wear. 18 of 19 that accepted it selected to continue with the walk aid versus the AFO. I'm not surprised by that. So they found improved ankle dorsiflexion during swing, hopefully. If we don't, they shouldn't be in the device. And then they found that allowed plantar flexion at push-off. So then when they ran them through the gait lab, they did feel that they saw that plantar flexion increased at push-off. And then the conclusions, it may be a superior alternative to bracing in individuals with mild CP, but it just calls for further analysis, particularly with motion analysis. And in my experiences with my patients that have gone through a motion analysis in our gait lab, it's very hard to see the benefit of the walk aid, because you do see a little bit of improvement in, that the dorsiflexion you do see on the video, you see it, but really with a lot of the kinetic data, it's very hard to see a clear-cut benefit. And then just lastly, the fun part is reimbursement, obviously. So you get the kid in, it works great, they can walk and run, the parents want it, and then you tell them that we probably won't get this paid for by insurance. So it's tough, but Medicaid, in the state of Illinois is not they do not cover walk aid or Bioness, and I don't expect them to ever. A lot of our patients that can proceed, they are self-pay or with some sort of foundation or charity assistance. There are a lot of pediatric resources out there. We've gotten together a pretty good list. I've worked with our local clinical specialists for walk aid, and we got a really good list together with resources for families. I'll put my email is on the handout. If you want to email me, I can send you those resources. And a lot of these are Illinois specific for us, but a lot of them have chapters in every state. So I'd be happy to send that. And then commercial insurance. I'd say I'm getting more approved now than ever before, but that's still a very, very low percentage. Some of the smaller commercial plans are paying for it, but generally I tell patients on our first submission, we're definitely going to appeal, and most of the time we're taking those appeals through to that third level where you get the, external review. So it is almost always an appeal. So develop your appeal letters and save them, because most of the time it's pretty much all the same. And, in the appeal letters, detail medical necessity. The big thing is try to get outcomes measures in there when you can, provide clinical notes, but also summarize the current research that's out there. Because a lot of times when they come back and say it's experimental or investigational, they actually, in the fine print, ask you to send research articles. So I just usually put kind of the notation and then a brief summary in my letters, so that's already done for everybody, so then I just change the personal information. So I have a lot of letters like that too that I'd be happy to share, so everybody can kind of keep adding to them. I did all that. And that's it. So be ready to appeal, and I tell patients that. I tell them they're usually going to have a couple weeks to get back to us, then it's going to be months, just so they're prepared. And that's why we use it in therapy and have those home assessment programs as well, so they're still kind of actively getting some benefit. So just in summary, kids aren't little adults. It's get used to FES with your adults and then start slowly applying it to the kind of minor foot drop, minor CP. Hemi kids. I would start probably 10 years or older just to make it easier on yourself, and then start bridging that gap down to the younger kids. Try to do a joint eval, or at least speak with the PT about the patient beforehand. And then you're going to start with a very low stimulation. You don't need to put any more electricity into the limb than it requires to get a movement. So start really, really low. As soon as you start to get it, I get the kid up and walking. If they're sitting in a chair, they're only going to tolerate me stimming their leg to get the perfect thing for so long, so just get them up and moving. And then one other trick that I started to learn is that, particularly with the walk aid, and you could do this with the Bioness as well, I can program it to their gait without even delivering any stimulation. So if they're just over sitting and having me do it, if I'm getting a little bit closer, I can even turn it all the way down and just have them walk. So I can at least start to program it before I keep just having them focus on me touching their leg. So it's a tip that has worked a little bit with some of the younger ones. And that's it. All right. Thanks.